Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is bringing curiosity, humor, and reflection to the world of palliative care. We're exploring the joys and challenges of working in this incredible field, including topics related to education, advocacy, self-care, service provision, and leadership from around the world. I'm one of your hosts, Dr. Megan Doherty, and today I'm at St. Jude Children's Research Hospital in Memphis, Tennessee, as part of their annual Global Scholars Program, which brings together 30 incredible healthcare providers from around the world. Learning and deepening their knowledge in palliative care is what it's all about. And I'm excited to be joined by Dr. Smriti Khanna from Mumbai, India, who is one of the St. Jude Global Palliative Care Scholars for 2023.
Welcome to the podcast, Smriti. It's so nice to have you with us today. Would you be able to just introduce yourself for all of our listeners?
Thank you, Megan. My name is Smriti. I'm Smriti Khanna, and I'm a pediatric palliative care physician. I'm from India, and I work in a tertiary children's hospital in the city of Mumbai.
Great. And we're so glad to have you with us, like I said. And we're really interested to hear from you because your team at this hospital, you've really been able to develop a palliative care team that's been very successful in reaching a lot of children. So can you tell us a little bit about this team? How did it come about? Where did you start from? Who did you start having on that team in the beginning?
So the idea of bringing pediatric palliative care to our hospital, it was really Vero's brainchild. So the head of my palliative care team, Dr. Veronique, she had this thought, she had this passion, I would say, about bringing pediatric palliative care to a hospital or to a group of children that really needed it. Mumbai is a commercial hub. It's a place where migrants come from all over the country. We get families from rural and urban areas, different socioeconomic sections. And I think the only common factor here is that a lot of them need a lot of care and support. So Veronique came up with this idea of starting the unit here. And I think that the most remarkable thing that happened was that this was actually the first pediatric hospital in the city. And it has been committed. It has a long history of being committed to children's healthcare. And they absolutely loved the idea. So they loved the fact that, yes, with palliative care, we could provide this additional layer of support that we all knew that the children needed. And I think that's how the program really got started.
So that's fantastic. Your boss came with this idea. And unlike sometimes how we see that the hospital needs to be convinced, in this case, it sounds like the hospital really saw that this would benefit children and got behind the idea right away. And then what about the funding? That's always a challenge for many of our programs to start. How did you find and get that in place?
I mean, I think that just as we were lucky with our choice of hospital, we were lucky with our funder. And they recognized that pediatric palliative care is an unmet need. And we're very grateful to them for that.
So you have one person or one that's supporting you?
That's right.
And who was on that initial team?
So we started with a team of 6. We had 2 doctors, 2 nurses, and 2 senior counselors. The doctors and counselors worked part-time.
It sounds like you did a lot of training in the beginning. You're telling me a bit about how you were spreading the word about palliative care around the hospital. What kind of groups were you trying to reach and how did you reach them in the beginning?
Our challenge at the beginning was really to get the message of palliative care across, to spread the awareness, because I think that even amongst general public, the awareness is low. And unfortunately, even amongst the medical community, the awareness or the interpretation of what palliative care actually means is not something that has been incorporated into our training. And so what we started was with nurse training programs. We started with having formal and informal conversations with doctors. Sometimes it used to be in the ward, sometimes it used to be on the lunch table. And that's how I think that the idea of palliative care and what we were doing grew. And that's where we got our first referrals from.
And how well was it accepted in the beginning? Once doctors, nurses heard about this idea of palliative care, were they finding patients for you, or how did it work when you probably saw some patients as you walked around the wards that needed this kind of care? Was it accepted if you could be involved?
I think that how it began in the beginning was that, yes, we had some departments who were absolutely happy to have us. I think oncology would be one of them, because the idea of having a relapsed child and not being able to do much for that child is an absolutely heart-wrenching one, right? And so they were actually happy that we were able to come in and give that additional support, pain relief, those kind of things. Non-oncology, I think, has always been a barrier to overcome. How we went about it is, I think, just by walking through the wards, looking at kids who we felt would benefit, and then having a conversation with the treating team, asking if we could help support them in any one aspect. It's very difficult in a hospital to look at all aspects of care, including the psychosocial one. And so we started with the psychosocial aspects, and then we moved on from there.
And were there places where there was resistance, and how did you overcome it if people were quite resistant to palliative care?
I think that for resistance, there are a lot of factors. As I said, we haven't been taught about the importance of palliative care in our medical curriculum. The way we approached it was, I think, one, by forming individual relationships with staff, with doctors, and trying to get our message across in that way. Another way that I think really helped is them actually seeing the effects of our work. And so if we were referred a child for psychosocial care and family ended up happier, or the family understood more about the disease at the end of it, the next time I would get a reference, I knew that I had a lot more leeway, and I had the ability to have a conversation with the doctor and say that, okay, I think that these symptoms also need to be looked at. Are you okay if we do that? And I think that's where we kind of went building strength by strength.
So building that trust amongst the other teams that you were going to do a good job caring for the patients, addressing their needs, and then they would trust you with more.
Yes, that relationship that takes time, and that's a two-way street. I'm actually quite glad now that we were patient about it, that we didn't rush into it, that we kind of just built that trust as we were able to.
And how big is your team now? Who's on your team?
We are now an 11-member team. We have 2 doctors, we have 2 nurses, 2 senior counselors, and 1 junior counselor. Some of our team members are part-time. We have a home care team that consists of a nurse and a social worker. And we have a book and toy librarian and clown therapist, which is not something that is a very common team member of other palliative care teams that you see.
That sounds fantastic. And again, is it all continuing to be supported by this one foundation donor?
Yes, and we're very grateful to them for that.
What advice would you give to programs that are newly starting out?
I think that if I reflect back on what we did well and how that has helped us sustain over the last 4 years, one is to keep the child in the center of everything that we do. And right from the beginning, I remember each time my counselors would keep bringing them back in all our discussions and say, no, but this is what the boy has said, or this is what the family has said. And that has really helped us. This idea that empowering in a paternalistic society like ours in India, or in a place where we have migrant families who may feel disenfranchised, who may not feel that they are able to speak up, but actually being able to sit down with them and empower them to actually speak up and ask the questions that they want to. This has been at the center of the shared decision making that we always talk about. And yes, we've had to contextualize it, but we've been successful at it. And I think that the other thing that has added to our success is the non-hierarchical nature of our team.
How did you build and make that team non-hierarchical? Because you're obviously in a very hierarchical medical system. We all are, but especially in India, I know this is a challenge.
Yeah, I agree with you. And I think that one ethos had to be in the minds of those who came into the team, that they were happy to work in an environment like that. But also, I'm in the wards and I'm seeing a child in pain. And yes, I'm prescribing gabapentin for him, but I know that my nurse is ensuring that he's getting the medication immediately and on time each time. I know that my counselor is speaking with the family or with the child and trying to make sure what else we can do to make him comfortable. My toy librarian is coming in to read to him. My clown therapist is blowing bubbles. And just knowing that in that moment, we are all doing what we can. And it's not just my gabapentin that's making that boy feel better. Just the recognition of that fact also adds to the non-hierarchy. And I'm happy now that we are in a place where everyone feels equal ownership of the team and of the work that we do.
And it sounds like putting the child and the family at the center has really allowed you to have that non-hierarchy, because no one of you is at the center. You're all kind of circling the patient.
Yes, because we're all looking to see how we can make that child feel better. I think that when somebody sees a child suffering, you really want to do everything that you can to help make him or her feel better. And just create an environment that allows that to happen, that allows everybody to reach the full potential of what they can do in order to make that happen. I think that has been the magic.
I think that's really powerful. You're in a big hospital, you see a lot of children who are quite ill, and this is a tertiary hospital. It has a big component of intensive care, both neonatal and pediatric. How did you work on integration into the intensive care units? Because that often can be quite a challenge.
I think one of the perceptions that we struggled with at the beginning was that palliative care is end-of-life care. And so the thought that, okay, we can only provide them to those where we have given up on therapeutic options for the child. And so that's one of the things that we struggled at with the beginning. But this whole concept of catering to the family psychosocial needs, I think that is what helped us. And so the intensive care team actually seeing that us being able to assist with psychosocial support, how that has directly impacted the trust that the family has in the healthcare team, in everybody that's taking care of him, how that's improving compliance, reducing DAMA rates, that is discharge against medical advice. And all that then contributed to that real-time better understanding of how any illness is not just biological, but it's biological, psychological, social, emotional, spiritual, all those dimensions. And so I think that was where we started with. And now we're at a position where we have a lovely working environment.
Let's talk about the initial referrals that you got. So in the beginning, you sort of mentioned about how the referrals were. And then over time, how have the referrals evolved?
I think that what it was that maybe in the beginning, we felt that we were not able to perform to the full scope of services that we actually had, that we had to focus more on the psychosocial aspects of care. But again, it's about building a relationship with the people that you're working with, building a bond of trust, and then being able to, once the treating team sees how you have helped the child and family get better also, then it's almost like, yes, then you have a seat at the table, then you have a voice, and then you can come up to them and have an equal stake in the child's treatment. And then you can say that, okay, I think that this is what they would benefit from. And I think these symptoms need to be looked at. And I think this child would benefit from home care.
Such a good example of how we really need to work together, and we have to build those relationships with other specialists, other teams. What are your goals now? And what were your goals initially? If you think back to the beginning when you started.
I think that when we got started, our priority was to be just accepted. Our priority was to be able to reach a stage where we had children that we could register for the service, and we could make a change in their lives, that we could help them get better. And slowly now I know that that is an established truth. I know that in my working in the hospital, in my day-to-day working in the hospital, I know that I will have patients being registered on the service date every day. I will have patients being seen at home care every day. And so now I'm able to focus on the quality improvement. If I want to strengthen my current capacities, that's where I will take this forward, establish a better bereavement service for the families who pass through the hospital, training opportunities. Child life services is something that we would love to develop, because we have so much of that with us. We have a wealth of knowledge and data, and work on improving and on training our medical and nursing capabilities. And I think that is where I want to go.
Thank you, Smriti, for being with us today. It's been fantastic to hear about your program, which really has brought a new level of pediatric palliative care to South Asia, and be glad to have you back on the show to hear more about it as you go forward.
Thank you so much, Megan. It was a pleasure.
Thank you for listening to this episode of the Sunflower Palliative Care Podcast. These podcasts grew from the seed of an idea as we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration, which focuses on children's palliative care. We hope to build a world where no child suffers from serious health-related suffering. To learn more or to donate, please visit twoworldscancer.ca.